So, good afternoon in Europe, and a very warm welcome to everyone around the world who's managed to dial in the KDIGO 2024 Guideline webinar today on ANCA-Associated vasculitis, giving an update on current management and treatment. My name is Silke Brix. I'm a nephrologist in Manchester in the UK, and it's a pleasure to have David speaking today on that update. David Jayne is a professor of nephrology at the University in Cambridge and also the clinical lead for the lupus and vasculitis service at the Adam Brooks Hospital. So when we talk about ANCA-Associated vasculitis, just a quick reminder, we're talking about here large, medium and small. We're talking about small vessel vasculitis, and we mostly concentrate often on the glomeruli when we see patients with ANCA. But I wanted to remind us that in the clinical scenario, you can have patients with vessel inflammation of varied size involved. And we have microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. We have 3 diseases. And the current hypothesis, that's the next slide, David, thank you. The current hypothesis is that the pathophysiology is we'll have the neutrophil in the center of the whole disease. And due to loss of tolerance, you have the buildup of anti-neutrophil cytoplasmic antibodies. And then due to a priming of the neutrophil translocates the cytoplasmic antigens, that is myeloperoxidase and proteinase 3, these two to the surface and makes them accessible for the ANCA then to bind and activate the neutrophil. And more recently, we discovered that there's a second activation step where the anaphylatoxin, that's complement factor C5a, binds the neutrophil and therefore recruits then even more neutrophils to the small vascular bed and has them then attaching to the vessel wall and sequestering and then netosing and dying. And this is causing then the vasculitis. Clinically, the vasculitis looks like this. So on the left, you have here the typical path staining. You have a necrotizing crescentic glomerulitis with this extra capillary proliferation, that crescent there. And if you then look into the immunohistochemistry or immunofluorescence, then it's not like in type 1 or type 2 that you have deposits, but you have rather an absence or scarcity of deposits. We're calling this then the porous immune type. That's the next. Yeah, the porous immune type. And while we have these 3 diseases, most trials and so KDIGO guidelines concentrate on the former 2, on GPA and MPA. So why did we need a new update of the KDIGO guidelines? Well, the recent 2 landmark trials were led by David and his collaborators. There was the Paxillos trial on the left with plasma exchange and steroid use, and on the right, the Advocate trial with complement inhibition. And these 2 have led to the working group where David is a key member working on an update. So we'll have David having his lecture now. Please put your questions while he's talking into the chat. I'll pick them up later in the Q&A, and so the floor is all yours, David.
So Silke, thanks for the great introduction, and hi everyone. It's good to have this opportunity to talk about ANCA-associated vasculitis, and I'm going to weave together some of the recent data that's informing management, some of the KDIGO guidelines, together with 1 or 2 illustrative cases. The first point is ANCA vasculitis remains a serious disease with an excess mortality, and this long-term outcome data from trials conducted in Europe shows, regardless of age group on the left-hand graph, there's an excess mortality compared to the background population. And when we look for risk factors, it's dominated by the kidney disease and by glomerular filtration rate at diagnosis. And the lower the GFR, the poorer the long-term outcome for patients. This really puts a premium on trying to diagnose this disease early before there is advanced kidney injury. In terms of the kidney, we recognize the typical presentation of an ANCA-associated vasculitis as that of rapidly progressive glomerulonephritis, where there's an acute kidney injury, there's normal-sized kidneys on imaging, and there's hematuria with proteinuria in the urine. And were we to look at urine, we would see red cell casts and dysmorphic red cells. Increasingly, as patients are being diagnosed earlier, we're now seeing patients with nephritis with a normal GFR, which from our perspective is the ideal time for patients to be diagnosed because it gives them the best possible chance of having a good long-term outcome. And it's essential that any patient with suspected vasculitis has a urine test for hematuria and proteinuria. If they don't, this will be missed. We do recognize there are some harder presentations of ANCA-associated vasculitis that is harder to diagnose. We recognize what we call a slow burn presentation, which is typically in older patients presenting with chronic kidney disease, where there may only be minor urinary abnormalities, that the urine may be largely normal. ANCA is positive, and the biopsy tends to be dominated by glomerulosclerosis. We do think, however, this is a lesion that does respond to treatment, and treatment will stop progression and may recover some function. We also recognize that patients presenting with ANCA-associated vasculitis without overt kidney disease can develop nephritis, especially within the first 2 years of their disease course. And then we recognize that some patients with renal vasculitis may be ANCA negative. This occurs in around 5% of biopsies of patients with porcine immune necrotizing crescentic glomerulonephritis. Now, moving to the KDIGO recommendations, if you have a patient with suspected kidney vasculitis and the clinical presentation is compatible with an ANCA vasculitis, the PR3 or MPO ANCA is positive, and you've considered and excluded possible causes of a secondary vasculitis, such as drugs, infection, or malignancy, then you can go straight to starting treatment and either defer or not do a biopsy. However, if the clinical presentation is less obvious, then a biopsy really becomes essential to guide you forward. Concerning management, once you've established a diagnosis, the initial goal is to obtain remission. Again, this is data from the European trials showing the impact on mortality and on end-stage kidney disease of obtaining remission at 3 months, which is the blue line here, as opposed to 6 months or not obtaining remission at all. So clearly, it's very important to try to get your patients into remission within 3 months. How do you do that? Well, clearly you assess the disease, having made the diagnosis, you commit to an induction regimen, and you essentially have 3 choices: either rituximab or cyclophosphamide, or the combination of rituximab and cyclophosphamide. Having made that decision, the secondary choice is whether to use glucocorticoid taper or whether to use avacopan. And avacopan is an option with all 3 of these immune suppressive combinations. The goal is to achieve disease control, or what we would call an on-drug remission. So how do you choose between these options? Well, rituximab is preferred for children and adolescents, premenopausal women and men concerned about fertility, and probably in frail older adults who will tolerate cyclophosphamide poorly. Rituximab also gives you a better chance of being able to wean the steroids off, and it's preferred for relapsing disease and PR3 ANCA disease. Cyclophosphamide is an effective treatment, and it should be available where rituximab is difficult to access. And many nephrologists still prefer to include cyclophosphamide or use cyclophosphamide in patients with more advanced kidney disease, where we do not have robust clinical trial data supporting rituximab without cyclophosphamide. The combination of rituximab and short course cyclophosphamide is promoted because some physicians feel there is a faster treatment effect. This permits steroid sparing. It is cyclophosphamide sparing because you only have to give 2 cyclophosphamide pulses, and it may be more effective than either rituximab or cyclophosphamide on their own. This is an example of retrospective data from the Massachusetts General Hospital, which uses a cyclophosphamide rituximab combination regimen and simply makes the point that regardless of ANCA subtype, they achieve a high rate of remission with this regimen. So moving on to a case, this is the first case of a 22-year-old South Asian man who presents with constitutional disturbance, cough, and hemoptysis. He has a slightly elevated serum creatinine at 123 micromoles per liter, which equated to a GFR of 55, elevated CRP and proteinase 3 ANCA, and he has blood and protein in the urine. He has bilateral opacities on the chest CT, and he undergoes a kidney biopsy where the majority of glomeruli show the crescent that you see on the right, but there is well-preserved tubular interstitium. This patient is treated with the rituximab cyclophosphamide combination. Rituximab is indicated in the vertical blue lines, and he achieves initial control, but actually at 3 weeks, there is a jump up in the creatinine and a jump up in the CRP. And so the cyclophosphamide course in this particular case is continued, and this subsequently leads to more complete disease control, and his creatinine normalizes. But what about steroids? Now, for various reasons, we think steroids are the major modifiable driver of side effects, particularly infections, in the treatment of ANCA-associated vasculitis. And the Pexivas trial, which investigated plasma exchange, also tested 2 oral steroid regimens. And this is really the only robust clinical trial data in nephritis that we have. We compared what we called a standard regimen to a reduced regimen, and the difference is the rapidity with which the prednisone or prednisolone dose is reduced. And I've shown you the regimens for different age categories on the right, and you can see the regimens aim to get down to 5 milligrams a day by 15 to 16 weeks. We saw no difference in terms of time to death or end-stage kidney disease between the so-called standard regimen and the reduced regimen. And so the reduced regimen is now recommended in the guidelines. Our hypothesis was the reduced regimen would be non-inferior with respect to efficacy, as shown in the previous slide, but would be safer. And indeed, we saw a significant reduction in serious infections with the reduced regimen. But please note that for this population, which is GFR less than 50, going down to dialysis requiring at presentation, we still observed serious infections in around a quarter of patients with the reduced regimen. So there is still some way to go to try to improve safety of the treatment of this disease. So moving on to a second case, this is a 74-year-old lady who had been unwell for 4 months, again with constitutional symptoms, had elevated inflammatory markers, normal kidney function, but was noted to have PR3 ANCA that was positive, blood and protein in the urine. Multifocal abnormalities on chest CT, compatible with a diagnosis of granulomatosis with polyangiitis. She was commenced on IV cyclophosphamide and high-dose steroids with good response of her symptoms, but after 2 weeks she started developing psychological side effects, being vague and withdrawn, developing very slow speech, and developing paranoid ideation, and she received a diagnosis of a steroid psychosis. Her steroids were reduced, and she was then given rituximab rather than continuing with cyclophosphamide, as she had a disease flare at round about 5 months. Rituximab gives you a slightly greater chance of being able to withdraw steroids completely without further flare, and indeed that's what happened with this patient. Steroids could be completely withdrawn. The patient recovered their mental health and was able to discontinue antipsychotic medication. However, the case highlights one of the more severe problems that we see with steroids. And it introduces the question of, do we have an alternative to steroids? So Silke, in her introduction, mentioned a role of complement in neutrophil attraction, neutrophil priming as part of the pathogenesis of ANCA-associated vasculitis. And the complement component C5a appears to be critical for the development of this disease. And in an animal model, taking out the complement C5a completely stopped the induction of ANCA vasculitis. So C5a is a terminal component of the complement system, part of the effector mechanisms of these pathways, along with C3. And avacopan is an oral inhibitor of one of the two C5a receptors, so-called C5aR, which is regarded as being the major pro-inflammatory receptor promoting leukocyte trafficking, migration, and activation. Following successful phase 2 trial development, avacopan was compared to a steroid tapering regimen very similar to the Pexavas reduced dose steroid regimen in the Advocate trial of 330 patients. Physicians could choose whether to use rituximab or cyclophosphamide as an immune suppressive, and you can see patients were randomized either to avacopan or steroids. Now, at 26 weeks, the remission rate was similar between both treatment groups, but at 52 weeks, for the endpoint of sustained remission, avacopan was superior to glucocorticoids. And you can see a 12.5% difference in the proportion of patients achieving this sustained remission endpoint, that is, remission by 6 months, staying through to 12 months without relapse. There were several key secondary endpoints, and here I'm highlighting the kidney, where in the avacopan group shown in red, there was more rapid reduction in proteinuria compared to the steroid group shown in gray. And over 52 weeks, we saw a greater recovery of kidney function in the patients with reduced GFR in the avacopan group, again in red, as opposed to the steroid group shown in gray. Key other secondary endpoints were a great reduction of steroid exposure, as you would expect from the study design, a significant reduction in steroid morbidity reflected in a tool called the glucocorticoid toxicity index, and improvements in quality of life with avacopan compared to the prednisone group. So in addition to the positive primary outcome, there were important key differences in the secondary outcomes. So avacopan has now been available for some time, and we are often asked the question, who will benefit most from avacopan? Well, I think this is a moving target, but when avacopan was first introduced, the patient groups that we considered were patients in whom steroids are contraindicated, patients with refractory disease that typically already have a very high steroid burden, and patients with a low GFR, reflecting the possibility that you can get better GFR recovery with avacopan. As we gain more experience with this drug, it's now becoming more desirable to think about the advantages of avacopan in more generally reducing steroid toxicity. And particularly, we appreciate the long-term implications of avoiding or minimizing steroids in this patient group. So moving on to a third case, this is a 63-year-old woman with a 6-month history, again, of constitutional symptoms, but here with cough and sinusitis, reflecting pulmonary and ear, nose, and throat involvement. She has elevated inflammatory markers and a positive PI3 ANCA, but no evidence of kidney disease. Serum creatinine was 63, urine was normal. She has significant comorbidities of type 2 diabetes and osteoporosis. And she had extensive bilateral pneumonic consolidation on her chest CT, but a bronchoscopy assured us that there was no evidence of malignancy and no infection was isolated as the cause of this presentation. We made a diagnosis of GPA with lung and ENT disease without renal involvement, and she was treated with avacopan and rituximab. She had received no steroids prior to her presentation to our department, and she received no steroids subsequent to our starting treatment. After a year, avacopan was stopped, and the current guidance is that if you're going to give avacopan, you should start it as quickly as possible in order to benefit from the steroid sparing of avacopan, and you should continue the drug for a year. We then introduced rituximab maintenance, which she received for 2 years, and then that was stopped, and she has remained well. And here we see the falls in proteinase 3 ANCA on the left and the falls in CRP on the right. And I emphasize this was in the absence of any steroid medication. And her CT scans showed progressive resolution with some residual scarring or atelectasis over the 2-year follow-up period. So having achieved remission, the question then is, how do you maintain it? And around 70% of patients with ANCA-associated vasculitis will relapse. And having a kidney relapse has been associated quite strongly with end-stage kidney disease risk and indeed with mortality risk. So preventing relapse is important. We really have 2 choices. We can continue rituximab for a period of time, or we can introduce an alternative oral immunosuppressive, which for patients with nephritis is typically azathioprine or mycophenolate, with or without ongoing steroids, again, for a variable period of time. And current recommendations are that we should continue maintenance therapy for between 2 and 4 years, and then withdraw therapy, and the patient hopefully continues with an off-drug remission. Now, the data supporting the recommendation for rituximab comes from 2 clinical trials where rituximab was compared to azathioprine following induction with either cyclophosphamide for the main Ritson trial on the left, or after rituximab for the ritazaran trial on the right. But the outcomes of the trials were the same, namely that there was a strong reduction of flare risk in patients given fixed interval repeat dose rituximab, and that is now what is recommended. It's important, though, in your management of ANCA-associated vasculitis patients to try to understand what factors may increase relapse risk in your patient. There are baseline factors, such as a diagnosis of GPA, having PR3 ANCA, having a better serum creatinine at diagnosis, having more extensive disease, and having ear, nose, and throat disease. All of these increase the risk of relapse. Then after the diagnosis, if a patient's had 1 relapse, they're much more likely to have another. And if they're ANCA positive at the end of induction therapy, or if the ANCA was negative and becomes positive, that is strongly linked to subsequent relapse, especially if they're being treated with rituximab. And then there are other factors related to treatment, such as lower cyclophosphamide exposure, stopping the immunosuppressive, or stopping steroids. So which should you choose? Well, we would clearly prefer rituximab for a patient who has a history of relapsing disease, because they will have quite a high exposure to conventional immunosuppressive drugs and steroids. We'd prefer rituximab for PR3 ANCA disease because of the relapse risk. For frailer patients, because we can more reliably get away without steroids, and clearly if you can't cope with the oral immunosuppressives. But a major problem with rituximab is a secondary immunodeficiency, so it's important to monitor the IgG level every 6 months. And if this is starting to decline, then we would avoid further rituximab, and some would then use an oral immunosuppressive in that setting, whereas others would simply pursue a watch and wait policy in the hope that the patient does not relapse. Clearly, oral immunosuppressives are cheaper and would be used if there was limited availability of rituximab. Now, I mentioned on the previous slide this concern over secondary immunodeficiency. This seems to be a particular problem with the use of rituximab in ANCA-associated vasculitis. This is a single study report from Cambridge where 40% of our patients developed an IgG technically below normal. The horizontal axis is over 15 years, and you can see some of these patients don't develop low immunoglobulins for a long time after the initiation of rituximab. But what we note is once they hit 3 grams a liter, they almost always require immunoglobulin replacement due to recurrent infections which are not prevented by prophylactic antibiotics. So please monitor the IgG if you're using rituximab, and as a rule of thumb, we try and avoid using more rituximab once the IgG dips below 5, but sometimes you're in a clinical scenario where you have no choice because the patient has active disease and you have to go ahead with rituximab. So that completes the presentation that I was giving, and I'm going to hand back now to Silke.
Thank you very much. I must say it's a good chat. I don't know if I've kept on top with all the questions. I think ideally is we'll go back just the last case to and roll it a bit backwards and start with the lady with the osteoporosis, because I had quite a few questions there. So for example, you had lung and ENT disease and you stopped your rituximab then after 2 years. So how do you decide your maintenance dose in someone who has ENT and lung and is a PR3? And would you have the same way paused your rituximab or stopped it in that sense after 2 years if she would have remained PR3 positive?
So in fact, we treated her for 2 years at the end of the 1 year. So in fact, we stopped the rituximab 3 years after her original presentation. And I think this is a very important question. The problem with stopping rituximab is that within 6 to 12 months, the relapse risk the patient had before you started the rituximab maintenance returns. And if you follow patients for, say, 2 years after you stop rituximab, around 50% will relapse. So the current advice is after you stop rituximab, you do need to monitor the patients carefully in order to try to pick up that relapse if it occurs. Now, we do place some importance on the PR3 ANCA level. And I mentioned in my presentation that persistence of PR3 ANCA in the rituximab era is strongly predictive of subsequent relapse. The inverse of that is if the ANCA has gone negative following rituximab, these patients have a lower risk of relapse. So we would routinely treat a PR3 ANCA patient with ENT disease for 2 years, and then we would look at the ANCA level. And if this was negative and the patient really had no features of disease activity at all, then we would stop the treatment and monitor every 3 months. The other point you need to consider for an individual patient is what would be the consequences of relapse for that patient. And if the manifestations are predominantly ear, nose, and throat or lung, you will pick that relapse up early because the patient will be symptomatic, and there are unlikely to be long-term consequences. On the other hand, if the primary manifestations of the patient are kidney, you have much more concern there because you may miss the relapse, and 10 to 20% of relapses are silent, especially if they're renal relapses. And in those patients, you would need to think about some form of enhanced monitoring, such as monthly urine dipsticks, to try to pick up renal relapse, because you know the long-term consequences of renal relapse are much more severe than for relapse in other organs.
And that means that if that person would have had PR3 positivity, you could have then, even if clinically in remission, you wouldn't endlessly continue rituximab. You would then, if it's ENT and lung, say, well, we are delaying it, extending the interval or pausing officially and monitoring. Yeah, okay. So then if we if we go to the next question, there were a few questions around the Avacopan, especially if access is to Avacopan there, people often not come directly to you like that lovely case where you didn't do any steroid treatments, but they come to you and are having received mitral red pulses, they are on steroids. So how, one question was, how do you switch from steroids to Avacopan? What regime would you use?
Well, in fact, the Advocate trial that I mentioned, the majority of patients were already on steroids with an average dose of 30 milligrams a day coming into the trial. And for those patients randomized to Avacopan, we withdrew the open label steroid over 4 weeks. So my recommendation is if a patient is referred to you with a relatively new onset disease and you decide to give them Avacopan, then it is safe and reasonable to withdraw their oral steroid over 4 weeks.
Okay.
There was a presentation last year at the American College of Rheumatology where we're now beginning to see real-world experience. And it was very clear in one of the abstracts that if you delayed the introduction of Avacopan, for example, waiting for approval to 3 to 4 months, you then miss most of the benefit with Avacopan because the steroid exposure is very front-loaded. So I think if you're going to consider Avacopan, you really want to try to start it as quickly as possible.
Good. And then there was a question. One is, you know, do we really need to stop after 1 year? When would you go for 2 years? What about thinking 2 years? And the second is, what I struggle with is if we're in an acute setting using GFR, which is probably not perfect, in the equity of providing Avacopan, saying in low, what is low GFR? So when would you say I really don't need Avacopan and get away not using it and be happy with steroids, you know, in kidney disease?
So there are really 2 questions there. One is how long should you continue Avacopan, and the other is what about Avacopan with low GFR patients? So the Advocate trial was 12 months. So we have no clinical trial data of exposure beyond 12 months. That's not to say you can't use it beyond 12 months, but we have no safety or efficacy data beyond 12 months. Now, there are registries being set up in Europe and North America, which will observe patients over 5 years, and some of those will probably continue Avacopan long term. So I think we will see more safety data reported in the future. So safety is one issue. The other issue is that Avacopan does reduce relapse risk, and that was shown within the 12 months of the clinical trial. And so in patients who are relapsing, and you don't want to use rituximab, for example, for hypogamma, I can see an argument for continuing Avacopan longer term, but currently that's outside the guidelines, and the guidelines are for 12 months treatment.
But that would be for the clinical picture, someone where you think you're really worried about little kidney function left, you're coming to the end of the year, someone is frail and has not really a lot of IgG. That would be a good case to say this patient, you perhaps have a good case to argue you stay on Avacopan.
I agree. I think we know that treatment withdrawal, and I think this is probably true of Avacopan, although we don't have the data, is associated with relapse. And I am concerned that if you stop Avacopan at a year and you do not have an effective alternative remission drug in place, those patients are at risk of relapse. So you do have to consider what to do. And I agree that you're going to be tempted to continue it in a patient for whom the other drugs are contraindicated. In terms of your second point, and this is low GFR, now in one of the phase 2 studies, we had an intermediate protocol where we added Avacopan to lower dose steroid as opposed to no steroid. And there was a little bit of evidence that they did actually slightly better than those given no steroid and Avacopan, not a lot. And so you could argue that for the patients with the worst presentations, there may be a benefit in combining a bit more steroid along with Avacopan. And that's sort of what we're doing at the moment with patients with a GFR below 15 who were not studied in Advocate. Advocate went down to 15, but not below. So for those patients with advanced kidney failure at presentation, or indeed for those patients with diffuse alveolar hemorrhage, we are using the Pexavas reduced dose regimen, and then we're giving Avacopan on top. That's not in the guidelines, but that's sort of what we're currently using. But I think, to your point, there remains an unknown, we don't know the answer to the question as to whether, say, in the GFR range 15 to 30 or 15 to 45, whether there might be a benefit of giving a bit more steroid to the avacopan patients.
And talking about the newer drugs, we shouldn't forget that when we say equity of care, there was one question, what do I do if I have someone who is not in remission after I have given cyclophosphamide and steroids, and I do not have access to rituximab or plasmapheresis? Can I just repeat or go on with cyclophosphamide?
So, I was very much brought up in the era when the treatment of this disease was cyclophosphamide and steroids, and the alternative drugs we had were azathioprine or methotrexate, and that was pretty well it. And we are aware that the current cyclophosphamide regimens, particularly with IV cyclophosphamide, are really quite low dose compared to the sorts of doses that we used to use with oral cyclophosphamide. And so particularly in younger patients, by which I mean under the age of 60, we often think that we're underdosing IV cyclophosphamide, and that's usually the cause of apparent refractoriness at 3 to 6 months. And the answer is simply to keep going with the rituximab, to give more, and unfortunately to give more steroids. But then, of course, you do begin to suffer from the cumulative exposure to these drugs, which is just what we're trying to avoid with the newer medications. But I think your question was absolutely right. There are these scenarios, which are not infrequent, where you're not achieving a disease control with the recommended drugs.
Okay, and then I think there are a few questions that go like into the stratification of, normally your patient isn't the standard patient. They're either a bit too frail or they're too young and have a bit too resistant disease. So if you would give us a tip of who is actually now a slow burner, how minimal can you go with treatments? If you really have someone where you say very little activity, what would you suggest you can do on minimal treatment versus someone who's the clinical profile when you really combine cyclophosphamide and rituximab from the start off because you're worried you want to be really quick and fast? So the two ends.
So I think when you're treating patients, you're always trying to balance the benefits of treatment and controlling disease against the risks of the drugs, especially infection. And one of the problems we have is that older patients tend to present with lower GFRs because renal disease is more common as you get older. And it's controversial, but it may be more aggressive in some patients. And we used to consider actually giving more aggressive therapy to older patients because we perceived their disease as being worse. But this was wrong. And what we found was just a very high rate of problems with the treatment. And what we've begun to appreciate that actually, although older patients can present with lower GFR, they tend to be much more treatment responsive than younger patients, and the true refractory patients tend to be the younger patients. So what do we do for the older slow burn patient? Well, we would usually use combination therapy. So we'd usually use rituximab with steroids. But we might start the steroids at 20 milligrams a day and aim to withdraw completely by 12 weeks, by which time we'd hope the rituximab was working. Also in older patients, provided you dose reduce cyclophosphamide for age, so that's 15 milligrams per kilo down to 12.5 for over 60, down to 10 for over 70, down to 7.5 milligrams per kilo for reduced kidney function and over 70. If you follow those rules, which are in the guidelines, then actually the risks of cyclophosphamide in the older frail patient are quite manageable. So I think the key here for the slow burn patients is more steroid minimization and steroid withdrawal, but then using either rituximab or cyclophosphamide.
And on the other end of the spectrum, where you say from the beginning, so I'm not going to hesitate, I'm going to go and do cyclophosphamide with rituximab combination, if you give us a clinical picture for that.
Yeah, so the typical, we tend to avoid using the combination in frail or the older patients, by which I mean over 85, or frail patients, because we think it is more toxic. But we definitely prefer it in the younger patients because we think the cyclophosphamide gives you a faster disease onset. And one of the problems with rituximab, particularly in nephritis, is that it works quite slowly, so you have to give a lot more steroid. And the original trial that compared rituximab and cyclophosphamide gave what we call old-fashioned high-dose oral steroid for several months. So the advantage of using a little bit of cyclophosphamide with the rituximab is that you can bring the steroids down very much more rapidly. And indeed, there are some protocols out there where the steroids are withdrawn within 2 to 4 weeks using the combination treatment. I think it's also important to appreciate that for younger patients who are concerned about their fertility, giving a total dose of 2 to 3 grams of cyclophosphamide is probably not going to be a risk, especially considering the severity of their disease. And so we reassure patients that this is well below a threshold that will have an impact on their fertility, but will have definite benefits for them in terms of achieving control. But Silke, as you know, what we did in the old rituximab trial was we compared the combination to cyclophosphamide and showed that it was non-inferior to a long cyclophosphamide course. But what we haven't done yet is to compare it to rituximab alone. Most of us feel the combo is better than rituximab alone, but we haven't yet got that clinical trial evidence.
That's true. Yeah. So there are many questions, but I think we'll probably have just one more around rituximab because there were a few. One was about how about anti-drug antibodies? Do you measure? When are you concerned? In which scenario would you check or try to check for them?
So that's a good question, and the reality is it's not a big issue. So when we developing rituximab for ANCA-Associated vasculitis, we detected anti-drug antibodies in around 30% of patients, but these were only of biological significance in 1 or 2%. By that I mean it prevented B-cell depletion. And in those patients with anti-drug antibodies, if you just use an alternative therapy for a year or so, the anti-drug antibodies spontaneously go away. And we have had rare patients that had clear anti-drug antibodies, failure of rituximab to deplete. We used another drug for a year or two and then rituximab again, and it was effective. So no, you don't need to measure anti-drug antibodies. I think we don't recommend routine B-cell counts except when you're not getting the therapeutic response you want. And then if a patient has failed to deplete B cells, that's a clear evidence of a failure of rituximab. So that's one occasion we would measure B cells. Say you're 4 or 5 months out, your patient's not getting better, we would check a B cell count.
And the last one on this, in rituximab monitoring, then when would you check for neutropenia? What's your experience? How often? And when would you look out for it?
So this is tricky. This is late onset neutropenia. It's unpredictable when it occurs, but it's most frequent around 3 months after rituximab. And I think the important thing is to counsel patients. So any sign of infection, that they alert you. In terms of routine monitoring of a full blood count, we would recommend that at 1 month, 3 months, and 6 months after rituximab. But even with that monitoring, you may miss it, because what tends to happen is the neutrophil count is well preserved, then it suddenly dips down and then it recovers. And you may just completely miss that with regular monitoring. So monitoring does not avoid the problem. You have to be alert to it, and the patient has to be aware that if they have symptoms of infection, they need to seek advice straight away.
Super, thank you. I think you've answered a lot of questions, and that was a wonderful Q&A session. There are many left, but I think we come to the 3/4 of an hour. So thank you very much. And do you want to advance that? Yeah, so we would like to acknowledge that the webinar was supported by CSL Vifor today, and thank you all for your attention and dialing in today. Thank you.